Our next speaker is going to be Dr. Lobel, and he's going to be discussing minimally invasive and lateral approaches to the spine.
Well, I guess we could have Vikram have us stand up and shout or whatever we did earlier this morning. Bear with me just for a sec because the slides are incredibly important, at least for me to explain minimally invasive. Done between minimally and maximally invasive that you have to understand. But minimally invasive spine actually represents what I believe the evolution in where spine surgery is going. Spine surgery, as we all know, we make these large incisions, we try to localize, we look at anatomical markers. By the time we really get in there, we've lost 500 cc's of blood. We have an incision that's a half a foot long. And given what I've seen with how people can manage their incisions in my limited experience at the hospital here, I am a little... What some of the concepts are that you have to understand with it is it's minimally invasive spine, as we see, has minimal tissue disruption, true percutaneous delivery, the small incisions that we all have. I like using local analgesics for pain control, which frequently includes a non-acute pump. We're now using Exparil, which is a lipid-based marking substitute. My wound closures are frequently with two different things. Pernio, is anybody familiar with Pernio or Durabond? I like using those products because essentially you're super gluing the incision and you don't have to manage them. So an individual can go back home, and if you're doing a microdisc, you don't need to see them for 6 weeks because your infection rate frequently is very, very small because of the type of wound closure you have. They allow for the rapid ambulation. I frequently will use unilateral techniques, but that's all based upon how large of an implant I put into the disc space. And then it's a developing and evolving specialty. I took this slide from, I think, the Journal of Neurosurgery, which came out, and it really demonstrates and shows how far we've come with minimally invasive spine, from the sextant procedure to the O-lift and X-lift, and now to some of the robotic technologies which exist. The robots currently are not allowing us to insert screws, but they're allowing us to identify the entry points, all based on navigational systems. Unfortunately, they're very, very expensive systems, and they're still in their infancy. But they do offer a continued evolution on how we do spine surgery, because as I said earlier, spine surgery brings more spine surgery. So if you want to get a patient in and out, and you don't necessarily need the same type of follow-up, and you're looking at limited resources where patients need to come in and out of the hospital with greater rapidity, these techniques will often satisfy that need. So the first grouping of procedures which I'm able to do through the tubes, microdiscs, T-lifts, X-lifts, I will expand it to other types of procedures, and here you can actually see the Luxor system from Stryker. I'm not on anybody's payroll, so I will mention things. And this, I think, may have been an old Zia screws or something with an implant. And here's the idea of how much space I need to do a T-lift. So that L5S1 procedure that we saw with the non-mobile or the micro-mobility with the spondylolisthesis, I can do a foraminotomy. I can completely open the facet joint, and I can actually fuse that through an 1.5 inch incision. Patient frequently can go home within 36 hours. So this kind of demonstrates, there's a quick image of what the capabilities of this kind of surgery is. So here I have a 67-year-old male with severe right lower extremity radiculopathy, and you have the sagittal T2 images along with the axials. And the pressure I had was he was going to New Zealand 2 weeks from his presentation to the office. Now, how many patients are going to be able to go out of the country and be able to tolerate surgery? I've also had a very similar case like this where a woman wanted to walk the aisle to get married, and blew a disc out. So whether it's a disc or a synovial cyst, as the case may be here, the minimally invasive surgery through a very tiny tube will offer an ability to allow these people to ambulate and return to their lives. Now, does that happen on every single case? No, not necessarily. However, it's very attractive to the patient. I know there are lights on here, and it's going to be hard to see some of the tube systems I use.
Can you just turn down the lights? Is that possible? Would that be better?
Yeah, it might be, if we can turn down at least the front lights, because this is important to see the actual tube systems. Everybody in this room can learn this surgery, and I think it's a very important skill set to have. But the hard part of these types of surgeries that I'm going to show is the fact that you have to have a three-dimensional image in your mind before you do these surgeries. There's a lot more fluoroscopic imaging. I was not trained on navigation, even though I can use it. I think every resident in this room, if you're doing spine and you're going somewhere which has navigation, first learn how to put in pedicle screws, then learn how to do navigation. Because if that stupid machine stops working, your case is over. So there are a lot of people in the United States who can't put a pedicle screw in without a navigational system. And I personally think, and forgive me for saying this, that's embarrassing. We are surgeons. You have to have an out for everything you do. So doing even the most basic microdisc, you need to realize you're going through a 2-centimeter incision with a 15-millimeter tube. And you need a microscope. My estimated blood loss is about 5 cc's. And a lot of people talk about blood loss and the complications with transfusions, which are rather significant. So I'm able to insert a tube into the patient's back. I localize with fluoro. So fluoroscopy is of the greatest necessity. It's essential. And this is the tube, which is right at the area of pathology. Your timeout is also exceedingly important in this because we talked about that, because you need to know which level you're doing, you need to know your laterality. And if anybody in the room challenges it, you always look at your films secondarily. There's a series of micro-instruments which allow me to operate through this opening, use a microscope. Once you're done, you pull the tube out, the fascia comes back, you put a stitch or two in the fascia, a couple sutures into the skin, close with Dermabond. Now, if you're doing a microdisc, one of the things that comes about is, well, what if I get a durotomy? All of us get durotomies. I get them all the time. I just don't talk about them. And there's a reason for it. Because when you make this incision, you don't cauterize the paraspinous musculature. You cut the skin over where you're going to put the tube, blunt dissection to the fascia, open the fascia sharply, put a cob down, continue your dissection to expand enough to put your tubes in. If you have viable tissue and you can make a simple closure, if you get a durotomy, all you're going to do is just get a little bit of CSF surrounding the area you're doing your surgery. No big deal. Open techniques, if you're cauterizing, killing the tissue, you're going to get CSF leaking out. So there are these advantages. I get all the same complications through the tube, but I think people tolerate it better because it's minimally disruptive. So this is the idea for the first type of surgery. I think it's the most basic, but believe it or not, microdiscs take me longer than XLIFs. So this patient, this is his actual surgery, went to New Zealand, had a good time, brought me a Lucky Charm, and I'm waiting for it to work. The next step we go is lateral surgery. The XLIF, the OLIF, it's evolving. Whether you go trans-psoas or anterior to the psoas, that's all based on the individual and your comfort zone. But this is another kind of surgery where understanding the anatomy is essential. This is an approach I do. There are some surgeons who insist on having general surgeons come in to do the approach. Doing a retroperitoneal approach is very basic, very simple, and can be done with one finger. But the bottom line is, you have a 52-year-old male, neurogenic claudication, axial back pain, had a cabbage, morbidly obese, poor physical condition. When asking how far these people can walk, they can't walk. I don't care what they say. They can't go up and down stairs, they get out of breath, they won't stop smoking, they won't control their diabetes. So again, if you want a big incision in your patient's back, that's fine. Don't send them to my office because I'm not a plastic surgeon and I can't fix their wound dehiscence, their infection, their osteomyelitis. The key is with this kind of individual who wants a quality of life. He has motor changes on his MRI scan. He's got stenosis. He has neurogenic claudication, and you want to get in and out, not necessarily quickly, but with as little blood loss as possible. So when we do these, this is, in my mind, an ideal lateral surgery. Again, intraoperative films, we can go through positioning if you want, but I think this is more to present the techniques, let you get a taste of it, and then get an interest in it. So this is a true lateral positioning. Unfortunately, where we were operating, the OR tables are not conducive to doing this type of positioning. But if you have an OR table which will allow you to position the patient true in the lateral decubitus position, you can localize your incision. For a 2-level X-lift, the incision's about 2 inches at most. It's entirely retroperitoneal, and being in the retroperitoneal space, in Ohio, my patients, the largest patient I ever did this on was about 450 pounds, and they're easy because the retroperitoneal fat is so substantial that it's easier to push the kidney out of the way, it's easier to get there, it's safer. Operating on much thinner patients, I get a little bit more uncomfortable because the fat surrounding the kidney and the retroperitoneal space is smaller. I don't like to see kidneys, and I especially don't want to put a tube through a kidney because I don't know what to do. You have 2 of them, who cares? But in all honesty, in neurosurgery, we only care about one thing, central nervous system. Everything else is optional in the body. You can replace the heart. You can be on a heart-lung machine. You got 2 arms, 2 legs. I mean, who cares? But I care when I'm doing my approach. So you have to be mindful of the anatomy. You have to look at the scans. Contraindications for doing a retroperitoneal approach electively: radiation, renal cell carcinoma, prior bowel perforations, things like that. But still, it's a very straightforward approach. This is the incision on the actual patient. These are my beautiful hands, Dr. Patel. You saw them all day yesterday working on a nice acoustic with me. And here's the tube system. This is a tactile surgery. So therefore, you have to understand the anatomy. You have to understand how things feel again, because it's based on the exam. So when I'm going in retroperitoneally, there's a feel for the fat. The fat feels spongy. It has its own tactileness to it, and then as you get to the lateral margin of the psoas muscle, that changes, and then you can pass your tubes through it. The tubes allow then passage for your dilator, and here in the circle is the actual X-ray of the tubes and the location of where I want to be. So you can see the disc space, and you can see the tip of the tube. That's usually about 120 centimeters. In Ohio, again, that's about 300 centimeters, but who's counting? So once you get your exposure, this is all you need. It's only a couple of centimeters, maybe 5 to 6 centimeters. Here's the disc space after I've cleaned it out, and this is the view that I have. Here's a more magnified view of the empty disc space, psoas muscle above and below, anteriorly. Here's some of the retroperitoneal fat. You've got a great exposure, very tiny space to work through, yes, but to the patient, they're much happier. So in the end, these are what the 2 implants look like. They're 26, these are 26s. So they're about 26 millimeters in size. They go clear across the disc space. They address the lordosis, re-expand the space, and provide the patient with a lot of pain relief. Here's another quick case that I wanted to show because people don't believe in direct decompression can actually open the spinal canal. This was a truck driver. He follows me to every clinic that I've worked in. He shows up randomly, and he smokes. He refuses to stop smoking, axial back pain, and he wants to be fixed. Again, if I hear patients say they want to be fixed, it is a red flag. You've got to know that patient. high narcotic dependence, no prior back surgery, neurogenic claudication with axial back pain. CT scans, I'm a big believer in the CT scans because you need to know your anatomy in advance. You can see rather significant motor changes on the 3, 4, 2, 3 level. This is his pre and post surgical CTs. Now, yes, there is some bony destruction in there. It wasn't an osteomyelitis, so I wasn't too concerned. I have a very large implant that I put in anteriorly, and this sagittal section really makes the end plates look terrible. I didn't do that. He did it to himself. These are the implants at the 2 levels, pre-surgery, post-surgery. I do a lot of standalone surgeries, and I speak to the patients because in the end I'll mention something about staging. Because long surgeries, in my mind, I do all the surgeries by myself right now. I have no assistance in the room. I'm lucky if somebody even knows what I'm doing. I've come into surgery where I'm doing a microdiscectomy in the thoracic space. I get a thoracotomy set. Now, I haven't done a thoracotomy since I've done X-lifts in the chest, but it's a little hard to do small things with big instruments. So here we have the pre and post. This is his MRI scan. These are, again, pre-implant, post-implant. You can actually see the indirect decompression. He is 4 years out of surgery, standalone implant, smokes like a chimney, hasn't changed anything in his life, and is doing well. There are nice revision techniques because if somebody went in, did an anterior-posterior fixation, he falls apart or his screws pull out, you got to open that whole incision up. You have no good exit strategy. So minimally invasive spine also provides the exit strategy because if I need to revise him or do anything, I have a virgin back here to work through and I can put screws anywhere in his back without difficulties. The last major type of procedure I can do through a tube, and I recommend everybody learning, is a T-lift. It is a workhorse for us with people with axial back pain and radiculopathy and can be done, again, through a very tiny incision. The idea of opening up spinal stenosis can be performed. All sorts of basic and larger surgeries can be done. If you look carefully, there's a series of dilators which are passed through the initial incision only after localization. The actual tube, which is expandable, is inserted in the patient's back, and then you're working with loop headlights, and you can look right down the tube. I don't advocate using a microscope because you tend to lose your field of view and it gets a little bit harder. Some people like microscopes. It doesn't make any difference. I figured I'd show an old Luxor. I am like a dinosaur in minimally invasive surgery. This tube doesn't exist anymore. I can't buy it on eBay, and it really is upsetting. But if you learn how to do the surgery, it doesn't matter. You use the tubes you're comfortable with, and you continue, maintaining your consistency. Here's an example of doing a spondylolisthesis. Again, my tube system is inserted. It hasn't been expanded. You can see a grade 1 slippage. The tubes are in place. Everything is marked off. The incision's usually about 2 finger breadths off of midline. I can also use percutaneous screws on the contralateral side, and it allows me for further reduction. Initially, I may put contralateral screws in first, percutaneously reduce temporarily, and then do the full T-lift on the ipsilateral side. You can gauge what was done from before to after, and these again are performed with maybe 10 to 20 cc blood loss. 20 is a lot for me, so it's usually 10 or less. The last thing I wanted to just go through really quickly is the idea of stage surgery. I stage most of my surgeries, in particular if I think it's going to require long duration or multiple techniques. In the last couple of minutes I have, this is an 87-year-old female. Her biggest complaints really had to do with respiratory issues. 87, you think I'm crazy to operate on, but this lady lived independently, worked out every day of her life, and would rather die than live this way. She came in, with a very positive sagittal balance, and was non-functional. I saw her 3 times before I agreed to do surgery. And I gave her, I told her clearly she could die from the procedure. So here are the CT scans. Already I'm thinking of doing lateral surgery followed by screw fixation. I show the pre and post implantation of the X-lifts to address her coronal balance and to open the space up. Then I did a short segment fixation, which worked for approximately 12 months. I chose to do a short segment, smaller instrumentation requirement, smaller incision. Her sagittal balance is corrected. She could actually stand up for her Christmas pictures. She was taller than one of her grandchildren after the surgery. Unfortunately, she developed a progressive kyphotic deformity above my fixation. I opened it up, fixed her one more time, stage surgery, low complication rate. And at this point, you can see what she looks like pre and post-op. But again, the X-lift really corrected her. Her falling forward may have been because of her activity level, or we can discuss that at another time. But here you can see the pre and post-op. These can all be put in percutaneously. There are ways to get the rods in. And if you use some of the minimally invasive techniques, even with your open techniques, you can minimize complication, you can increase patient satisfaction, and have a lesser degree of concern as your patients progress through recovery. So I apologize that my slides didn't come up immediately. I had to focus. I always need slides, otherwise I will meander and I don't know what I'll say, which we've discovered throughout this week. I would like to thank Victor and all the guys that I've met this week, everybody for hosting us. I've never been to this part of the world. It is a big change for us coming into the hospital. We're used to all the fancy stuff and all this and that. We've seen mice in the OR. We've seen bugs in the OR, but everybody survives. So, the staff's been great. The residents are fantastic. And, I really hope we do this again. So thanks for your time.
Thank you, Dr. Lobel. Any questions? While I'm putting on my slide, anybody have any questions?
Anything? When you decide to
Use the mic, please.
pelvic screws, never, because
when you have a long construct, Dr. Lobel, when you decide that pelvic screws are necessary or not necessary, this patient, I guess, over advanced age, she may not fall partially, give her a few years, good years. Say I was a 45-year-old person, would you be more inclined?
I would be more inclined to put a 45. I'd be more inclined to put in pelvic screws. However, in a 45-year-old, this, life expectancy she's already outlived, so this is more a quality of life issue. I don't have a lot of experience with pelvic screws, I'll be quite honest. And the trouble when we're doing long constructs, I wasn't really trained in doing these big pelvic screws. I think I need to do them with anybody that I go over past the thoracic lumbar junction. And I think it's necessary, or anybody's got an obesity question, or people are much more active. But I know pelvic screws can be put in pretty simply. I think they're a great screw. And yeah, I think she'll probably fail them below the time, so I would put them in, but my skill set doesn't include them, and I don't have people nearby to do them.
Thank you for that presentation. From the point of view of learning curve, knowing things in 3 dimensions, we are beginning to introduce minimally invasive surgery here. We have one of our champions not too far from here, from Eldoret, who is one of the younger neurosurgeons, and he's followed this up to the T. So I think he held a course recently. We've been to courses. Dr. Wanyeka and myself have done 2 courses, and the trade is supporting us. But what I must say is, for us who have learned the open approaches and have a 3D opinion of how fair these things are, it is easier to adapt and to adopt. my question to you is, in terms of the learning curve for the residents, this is an emerging thing, and for sure it makes a big difference in terms of how quickly patients leave the hospital. Besides the training systems where you have the soul etc., is there a way that we can incorporate them, where they can come to your centers if you've got cadaver dissections and so on and so forth, so they can spend time with you? So by the time they have live patients, they will not be studying so much so far. So is it possible for us to have that collaboration so that that skill set is built in their training? Is that possible?
There are companies, and I don't do a lot of training per se. I've had people work with me and follow me for a few weeks, learning how to do minimally invasive spine. There are some companies which have flown people from outside of the United States for cadaver labs, because I know there's a big issue with getting cadavers and doing live surgery. You are best served working with somebody who's done it. So the option, if you can't go there, is sometimes having people come to you, but you need all the equipment. To learn how to do minimally invasive surgery, you've got to do it. You have to make the leap of faith, and you have to know your anatomy. You have to master the basic techniques so that if you get into trouble, you know where you are, or you have an out. But companies, and again, I don't work for any companies, but the companies I've seen who've done it, and I don't know if they can speak for DePuy, I've particularly been on Invasive. Invasive's been a very large advocate for its lateral approach. I'm sure with Medtronic, and I don't know if Roger could answer to that, with the OLIF approach, which I think would be great out here, because you can do your corpectomies through these tiny openings, and you can deal with some infection through the tiny openings. So I think the companies themselves can offer that opportunity, and then how you expand it would really be sort of like a collaboration that Vic set up. But it's hard due to the fact that I need tubes here, reliable fluoro, and a bed. I think you guys need an operative bed because I use a Jackson table, and to not be using the Jackson table at this point would be hard. So there's a big investment all the way around, but I would start with the companies.
Thank you. Rebecca said there's a Jackson table she wants to get rid of. Is that correct, Becky?
Yeah.
Is that correct?
Yeah. Yes, we have a Jackson table. We need to figure out how to get it here. I believe our microscope is still held with customs.
It is still in customs, but anything like that, I would say the hospital would probably need to make some commitment to figure out how to get it here. You're offering something, the hospital needs to figure out how to ship it. That should not be your responsibility.
We'll work on that. Thank you.
Yeah.